Hello, my name is Keisha Ellis, and I'm a Doctor of Nursing Practice student at Maryville University of St. Louis. And this is my virtual presentation entitled Improving Depression Screening in a Primary Care Clinic Using a Depression Screening Protocol. First of all, I would like to extend a heartfelt thank you to all of those who have helped me with this project. First of all, I'd like to acknowledge Dr. Stegman. Your words of wisdom and encouragement has helped me tremendously. Even when I had a lot of trying times and setbacks doing this project, you never ceased to encourage me to move forward, even in light of adversities. I would also like to thank Dr. Snell and the DNP committee for allowing me to be a part of this program. It has been a lifelong dream for me, and I have been looking forward to this day when I would be able to complete my project. Additionally, all the instructors throughout all my courses in each semester, I thank you very much for guiding me along the way as I completed each phase of my chapters, and also for providing great and valuable feedback to me that has helped me to make corrections that have ultimately paid off. And last but not least, I would like to thank my community member, Dr. Heron. Not only are you a true friend, but also a great colleague who has given me a third-person perspective on what I needed to do with this project in order to help me to propel forward and be successful. I also would like to thank my husband and my other family for really supporting me during this time. You have all been a part of this journey with me. I know it's been filled with ups and downs, but I'm very grateful for you. So my project is about depression screening, and the hospital-based clinic that I completed this project is family-based, family practice, and it also has a walk-in component. Initially, when I started this project, I looked at data from 2021 about depression and how this was affecting the clinic population. I had a meeting with the CEO, Chief Executive Officer, Chief Medical Officer, as well as the clinic manager, and the provider that was there at the time was a PA, to discuss what I would like to do to make changes about the depression screening rates. And on average, they saw about 1,000 patients during the July 1st to November 1st, 2021 period. And my project was scheduled to begin as a retrospective chart review in 2022 around the same time period. I looked at the charts and there were multiple screenings, many of which had no results. There were multiple tools being used, Beck inventory, PHQ-2, PHQ-9, as well as others that I myself have not used in the past. And many of them had no referrals, even on the patients who screened positively. And there were also no treatment that looks like it was initiated by the provider as well. And more importantly, there was no follow-up on any of the patients that had received screening and that had positive results in the chart. And I discussed with them what I could do to help the clinic to improve these rates and also help the patient and provide quality screening as well as methods to improve their screening rates, as well as methods to facilitate either referral or treatment. So depression is a big problem worldwide. It's estimated about 300 million people suffer from depression across all races, ethnicities, cultures, and socioeconomic backgrounds. There are many reasons why people were not being screened at this clinic. Some of the reasons I heard from staff, as well as a provider. The provider wasn't familiar with how to treat depression, wasn't familiar with some of the tools and how to properly assess. There was not enough staffing to get the screening done. It was cumbersome on paper. The papers would get lost. They couldn't keep track of all the paperwork. They didn't want to ask the patients these personal questions. Patients didn't like to be asked these types of questions. No time, taking up too much time from clinical time, and the list goes on. I did discuss with the provider about depression in detail and explain that chronically ill patients with undiagnosed depression are at higher risk of mortality and morbidity. Untreated and unrecognized, especially, in this population can increase healthcare costs. These patients are likely to not follow their treatment plan, not follow up on their care, not take their medications, as well as not do the testing, for example, for their diabetes, or weigh themselves if they have heart failure, and also poor eating habits, not getting enough nutrition, and also explaining the risk of suicidality in these patients. If it's unrecognized for long periods and it's not addressed, they're at higher risk of suicide. Additionally, many depressed patients in this clinic not only didn't receive timely treatment, they received no diagnosis or referral to treatment. And the rates of depression, especially alarming in New Mexico, because the risk of suicide is much higher in minorities, children, and women in the state. Even in my local town of Roswell, we have a big problem with depression. Many of these people that we see in our clinic, they have high rates of depression, substance abuse, and other comorbidities, hepatitis C, for example, and there's several with HIV. So I felt it was compelling for me to address this, and I did note also in my research that in 2013, about 154 of the 1,000 emergency department visits in New Mexico were for suicide-related or suicide ideation for these patients that went to the ER. So the purpose of this project was to increase depression screening and access to treatment or referral using a screening protocol. The project had two primary aims: examine the research on depression and depression screening in primary care, and develop a screening protocol utilizing the patient health questionnaire. And secondly, implementing appropriate routine screening to reduce morbidity, mortality, and suicidality. Upon reviewing the literature, a search was conducted using the search engines Medline, CINAHL, PsycInfo, and PubMed. The search only included full-text English language articles between 2014 and 2021, but I did include a landmark study from 2001 because it was instrumental and relevant to my project in guiding my depression screening protocol development. Some of the keywords I used included screening children and adults for depression, chronic illness, screening protocols for depression in primary care, and screening tools and depression referral. My theoretical framework was Lewin's theory because I thought it was appropriate for this project since it examined behaviors, and we were trying to change the behaviors of not only the clinic staff, but also of the patients so that we could effectively recognize and address depression in this population. In Lewin's theory, it functions and acts as a catalyst for either creating a change or impeding a change. This theory is extensively employed by healthcare institutions all over the world to effectuate and sustain organizational modifications aimed at enhancing patient outcomes. And as mentioned previously, our goal was to enhance the lives of patients by reducing untreated depression, by addressing depression in positively schemed patients and giving them referrals as appropriate. There were three stages to this Lewin theory: freezing, moving, or change. First, identifying the change that is needed in practice, which was changing the way that depression screening was conducted. Secondly, explore the risk and benefits of making this change and propose this to the staff and stakeholders to garner support, then educating all of those who are involved, including the leadership, staff, as well as the providers, and addressing any objections that were brought forward by any of these people in these groups. And then lastly, the new concept, including the screening protocol, which I previously mentioned. Once that was accepted by the stakeholders, retraining on how to properly screen, using an appropriate screening tool, and getting a consensus of how this can go by performing PDSA cycles in multiple phases. As far as methodology, both the Institutional Review Board at Eastern New Mexico Medical Center and Maryville received a proposal to start this DNP project. Eastern New Mexico readily agreed to the project after I met with their leadership, and Maryville provided me an exemption because I was not directly dealing with any human subjects face-to-face. A retrospective chart review was used in this study to complete and evaluate primary outcomes of the study. Clinical education and training was provided on the patient questionnaire, depression in general, and how to properly screen, as well provide evidence to them about my screening protocol and how it was arrived. The screening was performed by the medical assistants who placed the results if the PHQ-2 was positive. They placed the results in a PHQ-9 form by completing that with the patient, getting a final score, and putting it under the HPI. The PHQ tool, PHQ2 and PHQ9 were both embedded in the electronic health record at the clinic, and depression scores were identified with baseline depression scores of mild 0 to 9, moderate 10 to 19, and severe being 20 to 27. Pre and post implementation data was then reviewed and compared with the PHQ to show the impact of a depression screening protocol, showing there was an increase in depression screening from the prior period in 2021 between July 1st and November 1st as compared to the 2022 period of July 1st and November 2022. And this is a depression screening protocol, which I will go over in detail. So the patient would arrive to the clinic previously. They would be checked in. All the vital signs would be completed. There would be room by the staff. And then their flag would be lifted once the vital signs was in the chart and medications were reviewed. And then the provider would go in and conduct their exam. When I started this protocol, I kept most of that. However, as part of the check-in process, the patient would arrive at reception, be checked in by the receptionist. A note was placed that the patient was here in the clinic. The medical assistants greeted the patients, measured their height, weight, took their vital signs, then took them to the room and completed the PHQ-2. The PHQ-2 was then entered in. If it was positive on both questions, the PHQ-9 would automatically continue question 3 through 9. And the staff would continue to complete the PHQ-9, then place a score on the history of present illness so the provider could readily access that. Once that was done, the flag was raised, the chart was closed and secured on the computer so that the provider could come in and review the chart. Then the provider would get in the room, review the chart, enter their information that they needed for the patient, review all the relevant patient information, review the PHQ-9 score that was there, discuss it with the patient, offer treatment if it felt appropriate doing so, or provide a referral to treatment. Secondly, as part of that assessment, the provider would ask about suicidality or homicidality. If the patient responded that they were homicidal or suicidal, 911 would be called, and the patient was taken to the ER where they could be admitted and evaluated further by staff in the emergency room. If the patient was not suicidal, the referral would then be generated automatically in the chart. The medical assistant would complete the referral process and schedule a 1-month follow-up to make sure that the patient was followed up on by the referring provider. If the patient refused a referral, the medical assistant would schedule a 2-week phone call so that the provider could reach back out to the patient and complete the reason why the patient didn't want a referral in the chart. The provider then completed their visit as appropriate or prescribed medication if the patient accepted. And then the patient went ahead and checked out, scheduled the 1-month follow-up with the receptionist. And if the patient was sent to the emergency room, then a note would be placed that they were sent to the ER. And then the ER would be the one that would set up a follow-up for this patient once they were discharged. Then the patient was checked out. So the inclusion and exclusion criteria were: participants ages 9 to 105 were included in the study. PHQ-9 was administered if the PHQ-2 was scored at a 2 or higher. participants were seen during the project period of July 1st to November 1st, 2022, and patients with a positive PHQ-9 were either treated or referred. The exclusion criteria included those aged under 9 or over 105, patient had no depression screening or diagnosis. If the patient had a depression screening or diagnosis prior to this project or was being seen by a mental health provider, they were excluded. If the EMR had no documented depression screening during the project period, they were also excluded. If the participant was screened with a different tool besides the patient health questionnaire, they were also excluded. A convenient sample was obtained utilizing the inclusion and exclusion criteria mentioned above and was placed in the SPSS data package software version 25 and analyzed. A minimum sample needed for this project was 154, but we did manage to achieve a higher number than that for this project. All patients were screened using the patient health questionnaire and screening protocol and part of their routine visit during the study period. So all patients that were screened during the study were done so as part of their routine visit. There was no separate visit that was required for this, and that made it extremely convenient for the provider and staff. So on analysis and discussion of the results, utilization ratio data was placed in SPSS. A z-test for the difference of two proportions was used for the study. A sample size of 154, as previously mentioned, was required to provide an effect size of 0.09 to 0.03, and the alpha value being 0.05 and a power of 0.9. Unadjusted odds ratio with a 95% confidence interval were calculated as a measure of strength of association and determined whether the results were significant or not. Since 0 was not part of this interval, we have significant evidence at the end of the study showing that there was a change in one direction, since this was a difference in two proportion. The achieved power of the study was 0.9965, which is considered iron strength, and therefore there was enough evidence to suggest that there was an increase in depression screening at the end of the study. So let's discuss further on the results. So on the upper tail, the p-value was less than 0.001, as we can see here, okay, pre-intervention, which was less than 0.05, which is the level of significance here. Therefore, there was sufficient evidence to show that there was an increase in the ratio pre-intervention. It was 37% that were being screened, and post-intervention it was 42%. The number of items of interest, these were the patients that we saw that were screened for depression with any tools pre-intervention, whether it was a Beck, the PHQ-2, the PHQ-9, that was 374 out of the 1,000 patients that were seen between July 1st and November 1st, 2021. And the p-value was less, as I mentioned, than 0.001 on the lower end. So on the lower end of the scale, we could see that the standard utilizing ratio here, 95% confidence interval, had lower numbers on one end of the tail. And then the p-value was 0.001 as mentioned. The confidence interval suggests that the true change did occur. And since 0 was not included, as I mentioned, there was enough evidence showing that there was an increase in the number. Post-intervention, the number of patients that were screened were 425. The number of the sample that was achieved between July 1st and November 1st, 2022 was 900. Level of significance was 0.05. Standard utilizing ratio was lower, which means that more people were being seen, and actually the protocol helped that utilization ratio to improve, not get higher. The strengths of the study: the positively screened patients were provided education and access to treatment. Educating all screened patients about depression recognition and treatment options was also important. Using the PHQ and a screening protocol allowed all patients that were eligible to have an equal opportunity to be screened. The project helped to decrease provider bias and attitudes towards depression, which in turn decreased stigma in patients. Screening helped patients to have both their physical and mental health needs addressed in one visit, and if they needed a follow-up, easily they could be scheduled for one or given a referral if they had mental health difficulties. The protocol and PHQ were embedded in the EHR, making it easier for the provider and staff to complete, and there was no papers to get lost or scoring that were possibly misplaced and later couldn't be found to follow up with the patient. Some limitations I experienced during the study included only one of the providers in the clinic participated in the study, which prevented some patients from the other provider from being seen. So only 50% of the actual patients that came to the clinic were seen out of the total that provider saw during the study period. And some positively screened patients declined treatment. We can't force treatment on people, so the provider offered referrals. Sometimes they refused that, as well as a follow-up. So there was not much else that we could do to facilitate possible treatment for these patients. But the provider did tell me that they did send a letter to the patient a month later and also asked the patient to call the clinic if they would like to discuss their depression further and get treatment at that time. Some implications for nursing practice in general. Depression is not addressed properly in primary care. There has been shown evidence all over that it's not being addressed properly. If we start addressing depression, we can help our patients to have a better quality of life. Using a depression screening protocol with an appropriate tool such as a patient health questionnaire will help identify depression severity quickly, and the provider can either treat or refer in a fast manner. Using protocols such as this in primary care to screen for depression is very helpful in developing protocols for other problems such as chronic illnesses, other types of mental illnesses such as anxiety. And routine screening by healthcare providers can identify depression quickly and get patients treatment and decrease the risk of suicide. So some implications for future research include this protocol, as I mentioned, can help or guide the development of other protocols to address chronic or acute conditions using evidence-based research. Setting up an alert in the EHR for annual depression screening will allow higher numbers of patients to be screened annually for depression. Methods used to develop a protocol can be applied to any area, chronic, acute, mental health, as well as others, and can help patients in the outpatient settings to have their medical and mental health issues identified and addressed in a much faster manner. Some implications for health policy, quality, and safety. Legislation to fund and expand access to screenings should be a priority for leaders, and increase financing to allow us to screen and treat, especially in those patients in rural areas with no insurance. Increased financing make it feasible to raise public awareness, advertising on television. Public health organizations talking about depression will bring awareness and allow patients to ask their healthcare provider about depression, or go to seek treatment if they don't have a healthcare provider. Also, it's important to collaborate between primary care and psychiatry so that patients that are screened, treated, or referred are followed up on to close the loop of communication and make sure the patients get what they need. Through healthcare reform and modifications, offering free healthcare to all patients to allow them to access care for their mental health would be very helpful in providing them with treatments and easy and early access. And lastly, the project detected cases of depression in a timely manner using evidence-based research and following national guidelines and recommendations for depression screening in primary care. And the project did increase annual depression screening of patients during a routine office visit in this setting. Questions? Here are my references. Thank you.